back?
No.
Oh.
And then
I didn't know this was part of it.
one more victim, please. It's not eating.
ABC, number 11. Step right up.
Come
That'll
on
be
over.
a good
She's eating.
combination.
She ain't eating nothing.
No, you're no fun. Get out of here.
I ain't
Amy,
even
get up here.
All right, there we go. Okay, first of all, I want to introduce Dina. Dina works with me. Of course, you all have condolences for her working with me, but the reason she's videotaping this is because Dean and I work with 17 other doctors that travel like we do, and we help develop their practices. And so we're videotaping this so that we can show them how we do these little presentations. So primarily it's going to be focused on me and maybe if you ask some questions or whatever, but that's the reason we're videotaping it, okay?
Can you get a copy of it?
Yes,
So
yes,
behave.
yeah. The other thing is,
They put all of us up here.
it's my turn to talk, okay? So, first of all, I appreciate being here. I'm going to try to start this off in a different way than I normally do, because I like to mix things up a little bit, and I've done this here before, and so I want to try something a little bit different. So, let's see. You are a patient,
I am Kim.
but you are a patient, okay? And this is your lunch,
Oh,
okay? Are you taping this? You don't want to miss this part. Okay. All right. All right. So this is a peanut butter sandwich, okay? And this yellow right here is the peanut butter, okay? And in a few minutes, you're going to take a bite out of your peanut butter sandwich, okay?
Okay.
You are a mother, and this is your daughter, okay? And your daughter is having her wisdom teeth taken out today.
Okay.
Actually, you need to switch places, or why don't we switch this up? You be the mother, okay? Did you like being the daughter?
That's fine with her.
Huh?
Am I going to be allergic to peanut butter?
Because she is allergic.
Because she really is allergic.
Okay. All right. So then let's switch, okay?
Flip it over.
And you're the mother, and you're the kid that's going to have their wisdom teeth taken out, okay?
Right.
And you are allergic to peanut butter,
I am.
but we don't know that yet,
Okay.
okay? So, in just a minute, you are going to take a bite out of your peanut butter sandwich,
Okay.
and then you are going to have difficulty breathing, okay? And you're to go, and then you're going to start complaining to your mom, I can't breathe, okay? And then you are going to freak out when you find out she's eating a peanut butter sandwich because your daughter is allergic to peanut butter, all right?
Who are you again?
And then,
I'm a patient eating a peanut butter sandwich.
Are we in the waiting room?
huh? Yeah, this is a waiting room situation, okay?
Okay. Wasn't sure.
And so then you're going to freak out and say, I need some help, okay? And then, of course, I'm going to come in and save the day, all right? Now, actually, huh?
Like the hero you are.
Correct. Did you get that on tape? Okay. So because you spoke up, you're going to get to be my dental assistant, Chris. Okay? So, all right, so Chris, you come over here because you're going to be off stage for a minute. Okay?
So this is all a big setup just to get you on film being a hero?
Yeah.
Pretty much.
Yeah.
I'm usually behind the scenes.
All right.
It's cool.
So, ready? Action.
Are you okay? What's wrong? Honey, what's wrong? Are you eating a peanut butter sandwich? You guys, I need some help over here.
What's
My
going
daughter's
on?
allergic to peanuts.
What's going on?
She's eating a peanut butter sandwich.
Are you okay? Why don't you just lay down right here for a second? Lay down on the floor right here. Chris, go get me the oxygen. And Lisa, would you call 911? What's wrong, baby? You can't breathe? Does she have any medical problems other than the allergy to
Just peanut allergies.
just peanut allergies? Okay, I need that oxygen in here. And is someone calling 911? Who's calling 911 for me? All right. I need that oxygen in here. And where's the emergency kit?
You're gonna be okay. You're gonna be
Can someone
okay.
get me the emergency kit?
We're gonna get you taken care of. It's okay. Why would you eat that in the waiting room?
Chris, can you go ahead and hook up this oxygen? Lisa, is 911 on the way?
I'm going outside just to make sure they know where to.
Do you have an EpiPen or anything?
I believe it's in our emergency medical kit.
Well, I carry one in my purse.
Okay.
Just hand me your bags.
I have a $600.
Can we get somebody to get her blood pressure, please? Okay. Let's go ahead and let's give her some oxygen. You got that thing turned on? Is it turned on?
No.
Do you know how to turn it on? Okay, good. All right. Okay. Now, I need somebody to take her blood pressure. Let's move this to the side a little bit. And can I get somebody, Chris, do you have somebody can help us ventilate her?
Since I killed her, can I help?
Man, you got peanut butter on the move.
Okay. So,
That's just
okay, so, all right, just don't put it all the way in her. She's got to be able to breathe. Okay,
This is my best friend. Come
All right.
on.
Here comes 911 killer.
okay. All right, so we're going to go ahead and give her a little shot on the EpiPen.
can't
All right.
wait to get to do it.
Okay, so that's it for the little scenario, okay? But the point is, do you see how quickly something like this can happen? It can happen anywhere in your office. It's not necessarily going to happen in the operatory, and it takes time and a lot of people to be able to do this, okay? What I want to do in a few minutes is start going over the presentation, but as you can see, everybody in the office needs to know how to get the blood pressure machine, get the emergency kit. You guys did a pretty good job on getting the emergency kit in place. But we're going to go over the specifics of all this stuff, okay? But it's not just something where the doctor needs to be paying attention. Everybody needs to be paying attention. So anyway, and let's give a round of applause to our actors and actresses. All right. Would anybody else like some peanut butter sandwich? Okay. Okay, so how long do we have? Like an hour? Okay. Okay. All right. Okay, so basically the title of this presentation is Basic Medical Emergency Prevention and Preparation for the Dental Office, 7 Habits of, it should say, a highly effective dental office in preparing and preventing medical emergencies in your office, okay? And why do I say habits? Let's go ahead and let me do the next slide. Oh, there it is. Okay. This is a book I wrote. See, there's my name down there. The 7 Habits of Highly Effective Dental Offices Who Are Well Prepared in Preventing Serious Medical Emergencies in their dental office. If you've seen any of my... What's that? I didn't really actually write the book. In fact, any of y'all that read any of my emails know that writing a book is outside of my skill set.
And that's on video.
Huh?
And that's on video.
Yeah, people tell me my emails look like terrorist ransom notes, but anyway. Okay, so the two stages, the two different categories are prevention, which is number 1, comes first, and preparation second. These are the habits, and the reason I say habits is because think about how rarely a medical emergency occurs in your office. Okay, so it's really hard to practice something that happens very rarely. So the idea is, let's incorporate these habits into your routine so that you're better able to prevent a medical emergency and be prepared in case one happens. So what are the steps? Number 1 is going to be how you, yes, it is hot in here. Thank you. What are your processes for reviewing your patient's medical history? When is it appropriate and how do you obtain a physician consult when you've reviewed the medical history and think that the patient might need to consult with the patient's physician? 3, we're going to talk about how do you manage a patient's anxiety and why it's important to manage their anxiety. how do you manage their pain? And then the preparation part is doing things like you're doing today, continuing education, making sure that your emergency kit is appropriate and available, and that you do periodic drills on using that emergency equipment. Oops. Okay, this next section is my favorite section because I get to talk about myself, which of course is my favorite subject. Okay, I've worked in over 300 dental offices. I've done hundreds of hours of continuing education. I've had the opportunity to actually, let me just back up a second. In the process of working in these hundreds of dental offices over my career, I've had a chance to witness not only the continuing education courses they go to and know the pressures that are on the doctors to try to not only be good at fillings, crowns, root canals, hygiene checks, all the systems that go on, but also medical emergencies. And then also see the different medical emergency kits that people have in their offices. And so what I tried to do in putting this course together is take into consideration all of the different pressures the dentist has and what they're likely to do and not do in their office to make things safer, as opposed to what typically they do is they go to a course that's 8 hours long, and that doctor that's teaching the course has to fill up 8 hours. And by the time the dentist is done attending that course, their brains are so fried, all they can remember to do is go out to the exhibit hall and buy the most expensive emergency kit and stick it in a drawer, okay, which does you absolutely no good. So that's what I've tried to do, is to condense the important information that I've learned in that 8 hours, apply that to the circumstance, which is the general dentist in the dental office knowing all their responsibilities. And so I want to give you things that you can do that'll give you the biggest bang for your buck to make your office a little bit safer, okay? So I'll just skip over some of my favorite stuff, which is about myself. Some of the forms, well, of course, you guys already have the forms, but some of the forms that I'm going to show you are on my website, but you also have copies of them here, which you can customize them for your own personal use.
How old were you in that picture?
Let's see here. By the way, that is a great question. And I'm just going to go ahead and skip to the next slide. Okay, so the information that I have is I've taken in from who I consider to be some of the best experts in the country. And it's important whenever you're kind of gathering information to make sure you're getting the source of the information from the best. And locally in Texas, we are fortunate, if you ever have a chance to hear Dr. Ernie Luce speak, he's out of San Antonio. David Canfield is well known here in the community. He does a lot of speaking. And Brian Henderson, who's a dentist anesthesiologist here in town, who happens to also be in our State Board of Dental Examiners. So those are good sources of information. And this slide talks about what I just talked about a few minutes ago, is because of my practice model and working in so many different offices, that I've been able to put together this course, which is a course that you're not going to hear anywhere else because of all the different uniquenesses of how I practice. And so we're going to skip that part. So here's the next thing. So when I was doing a little bit of research for this project, I would go up to a dental assistant in a dental office and say, would you go get me your oxygen, okay? And they would bring me something like this, okay? So I'd ask them to turn it on, and the tank is empty, okay? So if some examiner came in and said, do you have oxygen in your office? The dentist is going to go, yeah, but he's not going to know that there's no oxygen in there, okay? And since you see that little organism growing off of the tank there, it's probably not been touched in a while. Let's see here. Here's another example when I went up to an office and said, can I take a look at your emergency kit? This is an example of when a doctor went for one of those 8-hour courses and they went out and bought the most expensive, drug kit in there, and you notice the cobwebs, okay, around there. So I guess that's a good and a bad sign. The good sign is they don't have many medical emergencies in their office. The bad sign is they have no idea if the drugs inside are there expired. And then if you were being resuscitated, would you want this mask on your face? Okay. This was probably the most fun one that I when I asked the question, could you bring me your emergency kit? Up there in the container up there is cat litter. And so I asked the assistant, what is that for? And they go, that's in case they throw up. Okay, all right, well, you're prepared for that one. Now, the other thing is, you see this green tubing over there? It's a state law that you have to be able to provide positive pressure oxygen to your patients. Well, this is the apparatus to do that, except they didn't have a tank to hook it to, okay? Now, of course, they did have some syringes, but do you see any drugs there? No. And by the way, in my research, this is normal, okay? This is not out of the ordinary stuff when you go around to a dental office. This was another office that I went to, and I asked to see their emergency kit. Now, the thing that was bothersome about this is it actually looked like it had been used quite a bit, Let's see. Now, this is the example where the doctor went out and bought the most expensive emergency kit. The problem was he probably bought it 15 years ago, and I think there's one in there that's yellow. Anyway, all the drugs in here were expired, all of them, and half of the drugs in there, with my experience, I wouldn't even consider using, okay? So I certainly wouldn't want somebody that's gone to one emergency course trying to, start an IV, and because you have a tourniquet in there, which I'm pretty sure it would not even work. Oh yeah, here's I took the drug out of there. You see that yellow one? It was when they bought it, it was clear. Now, another common thing that happens is, of course, not in this office, but in most offices, there's a lot of turnover in the teams, okay? And so what'll happen is a doctor will go get the emergency kit or the oxygen equipment, and they'll store it in the cabinet where they store all their supplies. Well, then a new dental assistant comes in on board. The old one's gone, and so the new one doesn't know what's in this box, so they put something else in front of it. And so over time, it gets hidden. So when I asked this particular office where their emergency kit was, the doctor said, oh yeah, I've got one. But he asked his assistant for it. She's like, I don't know where it is. So it took him 20 minutes to rummage through all the cabinets to find out where it was. Okay, so as we go through this presentation, I will help you with answers to some of these issues. Okay, I was just kind of trying to identify what some of the problems are. Another concern is, what is the overall incidence of medical emergencies in dental offices? Okay, is it increasing or decreasing? Well, okay, let me back up. Okay, actually let me try this real quick. As you can tell, I'm not a professional lecturer, but you feel free to make fun of me at my own expense. Okay, let me see if this works better. cut, go back to the other spot. All right. The incidence of medical emergencies in dental offices, is it increasing or decreasing? Is it a good news or a bad news story? Okay. Dr. Malamed did a study, over a 10-year study, and over 4,500 dental offices, and he found an incidence of 30,000 medical emergencies occur in those 10 years in those 4,500 offices. So the incidence of medical emergencies in dental offices is increasing because of these reasons. Number one, the patients are getting older, so their medical histories are getting more complicated. And we're seeing more and more older patients. And we're also trying to do longer dental procedures. So 95% of the dentists that Dr. Malamed surveyed had had a medical emergency in their office within the last 10 years. So that's the bad news. What's the good news? That in 90% of those medical emergencies, the patient survived by just doing basic CPR, ABC stuff. So all the drugs, you know, let's not worry about the drugs right now. Let's focus on the ABCs, airway, breathing, circulation with CPR. That's where we need to spend the biggest bang for our buck. Okay, so where do these emergencies occur? 2% of the time, actually I'm going to sit down so I can see this thing better. 2% of the time they occur in the reception area. 55% of the time during the injections. 23% of the time during treatment. 15% after treatment is still in the office. And that's actually when they're viewing the bill. And then 5% of the time it happens in the parking lot. That's when the husband sees the bill, okay? So there's a couple things that you can gain from looking at this chart. Number one, your emergency equipment has to be portable, meaning you have to be able to take it to the reception area, to the parking lot. It doesn't do any good to say, yes, we have oxygen in the office, but the only place you have it is in the operatory, okay? And it also shows you that look at the highest incidence of when emergencies occur. That's when the patient's getting an injection, okay? So let's not give an injection and leave the patient in the room by themselves, okay? So just knowing that the most likely time for a patient to have an emergency is right around the time when they're getting the injection, by simply making sure somebody's in the room or at least paying attention to that patient, because you can give the injection and 2 or 3 minutes later, you know, the doctor's running off to go check hygiene, and there's the patient sitting there in the room by themselves, and if they start feeling crummy, who knows, maybe they'll try to stand up. Boom, they hit their head, okay? I had a patient that was walking through the reception area after we'd finished taking out their teeth, and the receptionist and I were sitting behind the counter here, and they had a marble floor, and all of a sudden we just lost sight of the guy, and we heard kaboom, and his head hit and bounced off the floor. So that's why your medical emergency kit has to be portable, and that's kind of what we demonstrated earlier on our world premiere movie. Okay, so typical emergencies. 50% of the time, it's just fainting, okay? Well, guess what? Fainting sounds like a no big deal, but look what just happened to this guy that was fainted walking through your reception area, cracks his head open, okay? So it's easy to treat, but you have to see and have to be around, you know? Mild allergy, chest pain, postural hypotension, that's when a patient's been sitting in the chair for a while and they try to stand up, and it's typically older patients or people with really low blood pressure. But in order for that, when they stand up, gravity takes into account, pulls the blood out of their brain, okay? And typically older people, my age, they're not in the picture you saw earlier, their blood vessels don't constrict as quickly, and they lose, they start to faint, So seizure, asthma, hyperventilation, epinephrine reaction, and hypoglycemia are the other issues. These are the, and by the way, this last list is by far the highest incidence. These all can be treated. You know, you can treat these in your office, okay, and have some, effect. These other ones, not so much. Only the one that you can probably have any effect on, which is probably the most serious, is the one we talked about with the peanut butter, is anaphylaxis. Okay, you literally can inject a drug and save their life, and it has to be done in 3 to 5 minutes after it really starts going. Okay, so let's go over these habits that we talked about earlier, one by one. Medical history review. I'm going to suggest that, let's see, we already went through these. Let me just, here we go, medical history review. Okay, I want you to take a complete and updated medical history on every single patient, every single visit. I don't want you to have a policy of doing it once a year. I don't want you to have a policy of doing it once every 6 months. I want you to have a policy like they do at the airport. Every time you get on an airplane, there's a checklist of things that they have to go through in order to say you're okay to get on this plane. So I want you to have a checklist of things that are required to be done before the patient goes in the back, okay? And that's going to be an updated medical history on every single visit and a blood pressure and a heart rate, okay? This is a copy of the medical history that I use. You guys have copies of it. This is kind of what we talked about a minute ago. That is, this is a suggestion I have given offices, and that is to put a blood pressure machine out here in the reception area. So the patients, when they sit down, there's a place where they can go get their blood pressure taken and sit down and fill out their medical history. There's a couple good reasons for that. Number one, it saves time in the operatory, so if the hygienist doesn't have to take their blood pressure out in the room, it's already taken. Also, you're likely to have a better blood pressure not in the treatment room, because once they get in the treatment room, their anxiety's going to go up a little bit. Now, I've been recommending this for years. Nobody does it. That is the blood pressure thing out in the reception area. But, the key thing is that you get a blood pressure and updated medical history on every single patient on every visit.
Dr. Roberts, do you feel like people might be just a little bit more shy when other people are sitting around the higher volume office?
Yeah.
And they're like, oh, look at their numbers are so higher, and kind of having some sort of input. Or, do you just want it like in a room, or just
Well, what I was primarily thinking was that that it would be done not in the treatment area for 2 reasons: efficiency, and you might get a better blood pressure, whether you do it out here or do it in the consult room. But again, no office that I've ever, I've done this probably 100 times, and no office is doing what I'm recommending on the blood pressure thing. That is,
Too many patients to
yeah.
be able to do it.
Well, that's cool. It's not a big issue. The big issue is get a blood pressure on every single patient on every visit. That is a state law. And get an updated medical history on every single patient, every visit. That's not a state law. Huh?
It is a hard copy because it's on the computer.
Yeah.
So each time you guys ask, every single.
Because literally, you could have a patient in here on February 1st, they go on February 10th, and they are all of a sudden put on a blood thinner, and they come in on February 20th, and you look at their old medical history. So
be part of that 100 offices that don't do it out in the reception area.
that's fine. That's fine.
We do a health history every page and every visit.
Okay.
And they don't fill it out. We ask the question.
Yeah, they get so mad.
Right. Well, and so the thing about it is, the best answer that I have to that one is, that's why we love working here, because Dr. Pincus is so conscientious and making sure that every I is dotted and every T is crossed. Your health and safety is his number one concern. And it's an inconvenience to us, but that's why we like working here. All right. Okay, so let's say you review the medical history and there's something on there that you're not sure about, okay? That is the doctor. What do you do? Well, I want you to have a system in place where you make it easy on everybody for the patient to get a physician consultation, okay? And keep in mind, it is not a physician clearance. You know, you can't just go, oh, the physician says it's okay and I can just do it, and if something goes wrong, it's on the physician because I got it checked. You know, it's a consultation. And so if something goes wrong, it's still your responsibility. So the question is, one of the questions is, when is it time to get a physician consultation? Okay? Every single doctor will have a different criteria of whether you should or you shouldn't, okay? And so I have a little system that I've come up with, which I call the red light, green light, yellow light system, okay? And you can use it for when to call 911, you can use it for when do I get a medical history, or when do I dump my boyfriend, okay? So, how does that work? Well, when you're approached with a situation, you have three choices. You have red light, green light, and yellow light. Well, guess what? The red light and the green lights are easy because you instantaneously know what to do. So when you're left with the only question you have is, what do you do with the yellow light? Well, there's two things you do. Number one, you identify it. It's pretty easy because if it's not red and it's not green and you're having to think about it, it's yellow. That's step one. Step two is to give it an arbitrary amount of time. I'm going to deal with this boyfriend for 6 more months, and I'm going to reevaluate, and after 6 more months, what happens to a yellow light if you stare at it long enough? Turns red, okay? So in this situation with the medical consult, you're looking at the medical history, and because your brain is going, maybe I should, maybe I shouldn't, then tell yourself, okay, I've got a yellow light medical consultation patient. I'm going to work on this for 6 minutes, 30 minutes, whatever, okay? If I can't get the answer that I need in 6 minutes or 30 minutes, whatever arbitrary amount of time you pick, then you get a medical consult. You stop the procedure and get a medical consult, okay? If you have one patient in your office that has that particular medical issue and you're not comfortable or dealing with it, by taking the time to investigate that one issue, whether it's asthma, bleeding, blah, 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 you probably have answered the question for 10 or 20 other patients in your practice. So that's why I say use it as a learning experience. Don't just think, oh my God, this patient's taking me forever and it's a bunch of a big extra hassle, because know that you can use that same information that you're using for that patient for other patients in your practice. All right, so the next step is, how do you logistically administer this physician consultation? You want to make it easy for everybody. And one way to do that is if you adopt my form that I created on medical consultations, okay? And I believe you see it up there on the screen. This is a form that anybody in the office can fill out. In fact, this could even happen before the patient shows up at your office. For example, if Dawn answers the phone and she does an initial interview with a new patient and the patient says, I've had a heart transplant, why bother wasting the time for the patient to come in? Dawn says right there on the spot, I'm sure that Dr. Pincus is going to want to get a consultation with your physician prior to your first visit. Let me pass along the form to you. And what the form does is it basically, tells the physician what are the possible medications that you would give preoperatively, intraoperatively, and postoperatively. So they're already written out in the top part of the form. The middle part of the form, and then the next where those 2 blank lines are things that you can fill in. Dawn writes down, patient reports having heart transplant, any special concerns, all right? Then the next, or the patient is diabetic, okay? patient is a diabetic. Can you please give us any instructions if they have to be sedated or something like that, okay? Blood thinner is another one. Patient's on a blood thinner, does this patient, can this patient be safely managed for an extraction either on or off their blood pressure medicine? I mean, on their, blood thinner. And then, or blood pressure is another one. Patient's blood pressure is whatever. So that's what those two lines are for, is to put any specific issues with that particular patient. Then the big square is where the physician fills in the information. These are all the questions that you want to know the answers to. And it says up there, number 1 is list all the current medicines. Number 2, list any known medical conditions. Number 3, any drug allergies. Number 4, are there any special recommendations or contraindications to the proposed treatment? Please be specific as possible. And then, do you feel the patient can be safely treated in the dental office setting, yes or no? The physician signs it, and the very last paragraph instructs the physician on how to get the form back to you. So this is all the information that you need to get a good medical consult. It's on one piece of paper. Just hand it to the patient, or facilitate it by offering to send it to the physician. So that basically makes it easy. So then the consultation comes back from the physician, and the dentist is looking at it. Okay. I've had several of these in my career where I've looked at it and the doctor says, hey, everything's good to go, and I still don't feel comfortable. So my next step is, if I still feel like it's a yellow light, I'm going to go ahead and call up the physician and talk to them about my particular concerns. This patient has atrial fibrillation, they've had an ablation, blah, blah, blah. Maybe I'm not sure what that means, so I want to call up the physician and talk to them about it. Or maybe the physician will write something on there like they sometimes do, no epinephrine. Okay? Do they really mean no epinephrine? Usually not. But you want to call them up and say, hey, look, blah, 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 the whole situation. Okay? So my point is, I've already made my points. And by the way, that wasn't supposed to be that funny, but I'm glad that you laughed. Okay, so anyway, quit distracting me too, would you? This is being taped. So my next thing is, let's talk about anxiety management. And why is that important? In that picture that you saw earlier of me, at that time in my life, I could jog 3 miles, which is 2 laps at my house, okay? Now, I can probably jog 3/4 or maybe 1 lap, but I feel like I'm dying the whole time, okay? That doesn't have to do with anxiety management, but as you get older, I really don't think that's funny. I have 4 kids, seriously. I'm glad you got a.
It's your fault.
All right, let's not go there. No, but as you get older, your body's ability to tolerate stress decreases. Okay. That's why. Well, anyway, and so a otherwise healthy older patient has a physiologic limit that is decreased from when they were younger. So what are some of the things that will add to that physiologic stress? Anxiety. Heart rate goes up, blood pressure goes up, okay? And if the patient's body can't tolerate that, things will start to break down. Heart attack, fainting, things like that. So that's why it's important to have a toolkit of anti-anxiety methods. Also, it's important to be aware, Don't, like if you walk into a patient's in the treatment area and they're starting to show signs of anxiety, asking a lot of questions, being fidgety, don't just ignore that, particularly in an older patient, So one thing that is good, which is why I have Christina and Austin work with me, is it's important to be empathetic. Is that how you say that? Empathetic? Okay. All right. Austin was trying to explain to me what that word means, but it's important. Huh? Am I saying that right? Empathetic? Okay. There was another word that he was trying to teach me. Huh? Well, I think it was I think there's this other word, kinderness or something he was trying to talk about, telling me. Huh?
Foreign language.
Huh? Kinderness? Kindness. That was it. Okay. So anyway, so it's important to address patients' fears, okay? Because that if they feel that you're there with them, they're going to be a little bit more calm, okay? That doesn't require any drugs or anything like that. And then the anti-anxiety techniques. I don't know any dentists I've heard about dentists that do hypnosis, but I don't have time for that. So nitrous.
I worked with one that did.
Yeah. So yeah. I mean, they're out there.
No.
Huh?
It didn't work.
Did it work? No.
I said,
No.
I guess it didn't work.
Well, anyway, so nitrous is good. The problem is, if a patient's really nervous, they're going to be talking and not breathing through their nose anyway. Okay. So just be aware that it has limitations. But in some ways, I think in some ways there's also a placebo effect and a calming effect that you can use the anti-anxiety thing and the nitrous mask, as a combo platter, hey, just relax, take a deep breath through your nose, everything's going to be okay. So both of those things can work well together. Oral sedation, I think, is unbelievably safe if you just follow the rules of the road, I think it's underutilized in dental offices. It's easy. I mean, you just give them a prescription for a single pill, same dose that you might give them to take it home all by themselves. Simple rules of, don't have them take the pill and drive to the office. Don't have them take the pill 45 minutes earlier at home, and then come, with a ride. I mean, they can trip on the, in the front. So have them come to the office an hour early, 45 minutes early. Have them take the pill here in the office. Supervise them in the office, in the operatory, Slip in a little bit of nitrous. Give them a couple shots of Novocaine, whatever it's called these days. Take off the nitrous. You're rocking and rolling, okay? Then when it's time to dismiss them, escort them out to the car like they're drunk. You know what that's all about. Anyway, I've seen you. And by the way, if you ever run into her at a bar, you want to party with her, trust me. Anyway, so, all right. And then IV sedation is what I do, okay? The IV sedation I do is basically trying to get the patients to the same level as the oral sedation. The advantage is with IV sedation, it works in 30 seconds or a minute. The oral sedation is much more variable. It could be 30 minutes, it could be 45 minutes, it could be an hour. The advantage of the IV sedation is I can give a little bit. 30 seconds later, if it's not enough, I can give a little bit more. With the oral sedation, although some people advocate it, I don't. It's a one-shot deal. You give them one pill. If it doesn't work, call it off, okay?
You don't use it anymore?
Huh? Oral sedation? No, it's a bad idea. It's a bad idea.
Sometimes with Halcyon, it feels like, there's certain people, like, you need to get that second dose
Uh-huh.
to really kick in.
Yeah, and the issue with that is, and listen, when I say listen, I mean, I don't mean to be disrespectful, just that's what I say sometimes, is listen. No, I'm just saying. But there are, I'm just trying to keep Dr. Pincus awake, okay? That's the only thing I'm trying to do here. I look over there, he's snoring, so I'm just trying to keep him in. I mean, he dances to get people's attention. I do this. Okay, so anyway, you don't want to see me dance. Anyway, even if you're drunk. But no, the idea behind giving a second dose is you don't know when the first dose has reached its peak effect. And so you may not know that you're like, okay, this isn't enough, but it's still taking its effect. You put the second one on, and now it goes farther than you want it to go. So and I know I'm being conservative when I make that recommendation, but I also can be 100% sure it's going to be safe, okay? As safe as it can be when you're basically doing the same thing that a patient is allowed to do at home by themselves, okay?
What's your initial dose? Like, are you giving them 0.25 or are you giving them 0.125 and then you're saying, well, now I'm not giving them 0.125 anymore to make it 0.2?
Yeah. There has been okay. There's a lot of stuff packed in that question because recently with the ADA they've changed the maximum dose based upon the maximum recommended dose. It used to be 1.5, now it's 1. So 0.125. The older the patient is, the smaller they are, the lower dose. Fact of the matter is, benzodiazepines, which is Valium, Halcyon, Ativan, they're like the safest drugs on the planet in terms of overdose potential, okay? I mean, you have to give somebody 1,000 times the normal dose to get them to stop breathing, So, I don't know. My personal feeling is you're going to be pretty safe with both 0.125 or 0.5 or 0.25, but what I like if I was working on Dr. Pincus over here, I would give him either 1.25 or 2 of them, which is 0.5. If you want to, if you have an older patient like myself, you might want to just give 0.25 or 0.125. But I mean, and see, the other thing is that comes into play there is if the patient has any drug history, alcohol or something like that, all bets are off because their their enzymes and everything and their liver is all just out of whack, and you could give them 4 0.25s and it acts like it's water to them. So that's the downside of oral sedation is you really can't titrate it. You can't give a little bit, see what their reaction is, give them a little bit more. So it works, and also you have to kind of characterize what is the definition of works, If you present it like, hey, take this little pill and you're going to go to sleep, you're not going to remember anything, that's a lot of pressure, okay? If you say to them, hey, I'm going to give you this little pill, and it's going to be like an emotional shock absorber, it's going to take the edge off, under promise, over deliver, you're going to feel less pressure to give them another pill. And keep in mind, you can titrate with your nitrous, okay? And what do you need the nitrous for beyond giving them the injections, So turn on the nitrous for a few minutes while you're in the room with the patient, giving them the local, okay? Then if you have to leave the room, you turn the nitrous off, make sure there's an assistant sitting there with them, and the patient is no different than if they're at home by themselves. Now that's not true if they've got a rubber dam on and a bunch of stuff stuck in their mouth. So, I mean, at that point, you're basically safer than if they're at home by themselves taking the medicine, okay? I hope that wasn't the police or anything. It's a warrant out for my arrest. Okay. Huh? Okay. So anyway, all of these techniques have failure rates, okay? And so when one doesn't work, go to the next step. And the next step, and I think we had a patient here about a year ago where I tried to sedate them with an IV and it didn't work out. I said, done. I've exceeded my comfort level. I didn't try to give them more drugs. I said, this is outside of my scope. I aborted the mission, talked to the parents and said, hey, we need to get this guy back and we need to take him a little bit deeper, which is when I called in the anesthesiologist to come in. For HIPAA purposes, we're not going to explain, what the patient's name was. Just kidding. Huh? Oh, you are HIPAA-fied? Thank God for HIPAA. Okay, so pain control. So we were talking about how anxiety increases a patient's workload on their heart and their cardiovascular system. So does pain. So if you have a fragile patient, just know that making your office safer is done by decreasing their anxiety and decreasing their pain. Because the less cardiovascular stress they have, the less likely something's going to blow. So how do you do that? Well, you know, it goes without saying, but I'm saying it, do your best to make sure your patients are numb. If they tell you they're not numb, they're probably not numb, you know? And also know that if you're working on a patient and you're hurting them, your office is less safe. Very few dentists learn much more about local anesthetic after they get out of dental school. And so there are hands-on local anesthetic classes that you can take. Learn about supplemental ways to administer local anesthetic. So habit number 5, get in the habit, and I really do have to give your doctors credit here for having me come back here, because I think this is about the 3rd time I've done this. And I don't know, maybe there's one other office I've worked in that has had me come back a 2nd time. I try not to take that personally, but you know, I guess no, but seriously, the commitment that they have to take, I mean, it's not cheap to pay you all to be sitting here, okay? I mean, so it's really, you really should feel, which I'm sure you already do, this is a special place to work. It really is. And it's not just because Dawn's here. All right, so doing these continuing education experiences, I think it's a good idea when you update your CPR to call an instructor to the office and do it all here as a team. Oh, I know, hold on. If you are going to look for a really quality source of continuing education, the American Dental Society of Anesthesiology, I think, has the best courses and the highest quality instructors in the country. The next habit is, let's talk about your emergency kit. What are the things that you want to have in your emergency kit? Do you want?
Everything Dr. Roberts tells us.
Correct. But, you know, kind of I mean, do you really want, if your kid's having a problem, do you really want some doctor looking in an emergency kit and then looking at a little cheat sheet and say, oh, this amount of medicine? You know, no. So let's not put anything in your emergency kit that you're not as comfortable using. You want to sit here and say, oh. No, what were you saying? Yeah. So I mean, if you're the doctor, look at your emergency kit and go, if I'm not like as comfortable as using this as a telephone, you know, and I'm not saying instead of a telephone, you know, instead of a good, you know, I'm not saying don't have anything in your emergency kit because you can always call 911, but if you're, you know, if you're not like that quick on what to do with this, it's probably either not a good idea to have it in your emergency kit or get to the point where you are that comfortable with it, okay? So, do you know how unbelievably distracting that is when I'm trying to concentrate up here? And this is being videotaped too. I mean, come on. All right.
Now we have to start over because you lost your track.
Correct. All right. So these are the things that I recommend that you have in your emergency kit. I forgot to bring them, and maybe Dina can mail them to you.
I think we have that. I think you gave us that.
Yeah, this
One in
card.
our break room.
Yeah.
I think we have that in our medical kit.
Yeah.
But what is romazicon? Is
Yeah.
that naloxone or is that flumazenil?
Okay. The answer to your question is yes and no. Romazicon is the reversal agent for benzodiazepines, which benzodiazepines are Valium and Halcyon, okay? naloxone is a reversal agent for narcotics, like fentanyl and Demerol.
So we
You know,
don't have a reversal program.
you don't need one.
We don't?
No.
Well, because does Romazicon have to be done IV like flumazenil?
Okay, romazicon and flumazenil are the same thing. Okay, just different. One's a trade name, one's a chemical name, and most people that I know that I think are experts feel like you have, if you're going to use romazicon or the reversal agent, it has to be given IV. Okay?
We're not equipped to do that.
Huh?
We're not equipped.
Correct. Now there's a few folks out there that say, you know, draw it up, stick it underneath the tongue. Okay?
How much?
Well, it's 2 cc's, but here's the issue. A person that's had too much benzodiazepine and you feel like they're not breathing, all you have to do to get them to breathe is tilt their head back and open their airway up, okay? Call 911. Because they're not breathing because their respiration has been so depressed they can't breathe. They're not breathing because their airway has been occluded, okay? So romazicon, the benzos are not going to stop you from wanting to breathe, but they may relax you so much that your head's cutting off your airway. So why not, in the person that doesn't, the resuscitation, or resuscitator, if that is a word, sounds like it is, yeah, doesn't know how to start an IV, then let's concentrate on keeping the airway open, administering the oxygen, calling 911, because even if they do take the time to draw up the romazicon, stick it under their tongue, it's going to take 15 minutes to work anyway. You see what I'm saying?
We have to have it in our kit, just to have it.
At this stage of the game, I think you do. Okay, I think you do have to.
Naloxone also?
No,
Okay, because
No.
we do get that every year.
I was told
But
in
see,
my
that would
emergency
never-
medical class that we had to have flumazenil and naloxone. in our
Okay.
kits.
all right. Well,
If we don't, we'll put order in naloxone.
yeah, I don't think you have to have naloxone. Okay, you know, I mean, I'm trying to think of the, you know, because you're not giving in this office.
Anything that would be caused.
Yeah, it's,
Yeah, but so many people, they said that we have such an opioid addiction in this country that if we gave them something and they were on an opioid and we didn't know that, their system could depress from the halcyon because they're already on stuff we don't know, and the naloxone might reverse the opioid that they were on, although it won't affect the halcyon.
and
That is what the thinking is.
and I agree with that thinking, but the question was, do we have to have it? And from a you know, State Board of Dental Examiners perspective, I don't think that you do. But, you know, is it a bad idea? No.
So do you
But-
do the other thing to order?
But again, if in the scenario she's talking about, let's say it's an opiate addict, because the two drugs actually work together, and I'm going to use a big word, synergistically. Okay, yeah. So if you do reverse the one, then you're basically getting back to where they were before they got here. So anyway, so that's the next thing. So what else?
Okay, so question, so if we're gonna get romazicon,
Mhm.
I mean, does it matter if it's romazicon or flumoxamine?
No.
It's the same thing.
Doesn't matter. The issue with the romazicon is the shelf life is only a couple years.
Oh, most.
The naloxone is like 6 months.
Yeah.
That's the thing, it was expensive, and then we looked at the expiration date, it was like 6 months.
I don't think naloxone should be that expensive.
It is now.
It's
Oh,
on
yeah.
now, and we got it in the automatic ejector instead of having to drop the syringe. we
Yeah.
got the automatic
Now the
ejector.
automatic ejector is going to be more expensive. Okay. I mean, it's kind of like the EpiPen. I mean, that was on the national news about the EpiPen. But you can get a vial of an ampule of epinephrine, 1 to 1,000 in 1 cc. You can get that for like $5, and you get a syringe for $3, and you just drop
I don't know if any doctor here would do that though.
But if you could draw, if you just draw, this is the important part. If you just draw up a third of a cc, that's the same medicine that you're paying $300 or $400 for. Huh?
Depends on whether the doctors are equipped to do it, because I mean, I'm gonna grab an EpiPen and I
Well,
can do
the
it, but I'm
issue
not gonna
is,
do that.
what if we're not here?
Right.
So use that as a
Right.
Yeah. So anyway, those are those.
Not be here when there's a patient here,
But I mean,
saying, like,
Well, what if the UPS driver came in on Friday and something happened to him right here and there's nobody here but somebody at the front desk? They're not gonna
That ain't
draw
our
this
patient.
in, and that could happen. I mean, that's the crap that happens when you don't expect it.
well, as an example,
but if we had an EpiPen, we could do it.
yeah. So I mean, I mean, there's different. You know, if you're talking about what's morally and ethically appropriate, that's different than what's legally appropriate. Okay, and having an EpiPen for the UPS guy is a moral and ethical issue.
Right, not illegal.
It's not a legal issue. You know.
Yeah.
So I stick with the legal. Anyway, no, just kidding.
I feel like EpiPen is one of those situations that happens more often in terms of medical emergencies. And if they have to come find one of us to go draw the thing up, when we
Yeah.
really could just take it out and stick it. I'd rather make them every 2
Right,
years
that's
when
how
it expires.
right, that's how
For peace of mind, to let everyone know how to take the top off and stick it. I'd rather do that than watch us draw up the proper amount and do it.
Do we have time for a funny story about EpiPens?
Yeah.
And in some ways, it's kind of relevant. Okay. Well, I'll let you guys decide. So I'm sedating a patient for another doctor, and obviously because of my ADD personality, I was incredibly bored. So I was thinking, what can I do with myself during this time? So I thought, let's review. What's the end of this story?
You shot yourself with an
The
EpiPen.
epi in the finger,
Thumb.
and did it swell up or turn white?
And
You're not the only one that's done that, at least.
I think the reason I'm sharing this story is, along with the personal humiliation that goes along with this, there is a good lesson here, okay? Yeah. So anyway, I accidentally injected my thumb with the EpiPen, and all of a sudden I started thinking about the reason you don't give epinephrine to, a part of your body that's towards the end of the circulatory system is because it causes constriction of the blood vessels and your thumb could fall off. So, and then of course I'm also responsible. Really, are you getting a big kick out of this? I could have died.
You can have the story true, you can laugh.
You're here to tell it.
The end of the story is I lived and my thumb's still working, okay? No, but I'm just going back to that moment. Number one, I'm thinking my thumb's gonna fall off. Number two, I'm supposed to be responsible for taking care of the sedation on this patient. What's gonna happen with my heart now, okay? So, but the stuff only lasts for 5 minutes in terms of the heart effects. So I'm like, okay, after 5 minutes, I'm good. Well, then, after about 30 minutes, the tip of my thumb started going numb. And over the next 45 minutes or an hour, my whole thumb was going numb, okay? And so in between that office and the next office, as it was getting number and number, and I'm starting to panic more and more, I just stop off at an emergency room at a, yeah. So I ended up going to an emergency room and just, sorry guys, yeah. So anyway, and the doctor basically said, it's probably gonna be okay. If it's not better, yeah. He said, if it's still numb after about 6 hours, you probably should go see a hand specialist, okay? So 6 hours later, it was still getting number. And so at the end of the day, I went to another emergency room and they called in a guy and he starts talking about, you could have injured the nerve that goes to your thumb and blah, blah, blah. And if that happens, if it doesn't feel better by tomorrow, you might have to have a surgery to fix your nerve. Well, anyway, fortunately by 10 o'clock that night, it was back to normal. Yeah,
How
so,
many sets of wisdom teeth did you
Huh?
try with the numb thumb?
just 2. So anyway, it was just hard to hold the retractor, but.
Yeah.
What hand was it?
Are you right-handed?
Mhm.
That was a good lesson learned, though, wasn't it?
Wait a minute. You know what?
That hurts like
Anyway,
that.
huh?
It hurts like
Well, the point is, when you have, there's 2 caps on that thing, okay? And anyway, so it might not be a bad idea to just kind of, I think they have those tester ones,
Yeah.
with the
See,
training
ours is
wheels.
different than we did the generic brand.
Yeah. So anyway,
So it's
that's what you do when you do your emergency drills, is you open this stuff up, you look at it, you play with it.
Sharpie and put which end is the.
Yeah. So anyway,
That might be smart if you
all right, so, okay, it's now 1:15. How much time do we have?
My first patient's at 2.
2? Okay, let me, I want to spend at least 20 minutes on the oxygen side of things. So we'll just run through this real quick. Ammonia inhalers are basically just to cause pain. You can either do that or you can just, pinch somebody or slap them. Patients that are asthmatics, tell them to always bring their inhaler with them, but sometimes they're going to forget, so you need to have your own inhaler here. People that are diabetics, patients aren't going to have a short-term problem if their blood sugar is too high. But if it's too low, they can have a short-term problem. So if a patient that's a diabetic crashes on you, you always give them sugar, even if you don't know if they're high or low, because if they're too low, you can bring them back to where they need to be. If they're too high, you're not going to do anything long-term making it worse by having them even higher, okay? So it's a good idea to have a source of sugar around the office. All right, the next thing is nitro. These bottles are great because you can use them, over and over. The expiration dates are longer. The problem is they're really expensive as compared to the pills. The issue with the pills are they're very, very cheap, but once you open the bottle, they're no good after, I think, 6 months. So my suggestion is to not get the spray, get the pills. If you ever use them, throw them away, throw the bottle away and get a new bottle. Okay, here's the EpiPen, which I just went too far. We already talked about that. I don't know. Anybody around here know how to use a computer? I sure don't. Okay, there's the EpiPen. For mild allergic reaction, it's not a life-threatening situation. So you can either use pills of Benadryl or you can get these pre-filled syringes, which again are going to be pretty expensive. It's just an IM injection. You squeeze right into the muscle. But, no one's died of a mild allergic reaction. So the difference between the pills and the injection is the injection into the muscle is going to take effect in 5 to 15 minutes. The pill may take 30 minutes. Do I keep doing this backwards? If someone's having a heart attack, you can give them aspirin to help dissolve the clot. But other than that, if they're having a heart attack, you can't do a whole lot, in terms of any medicines administered. Why does it keep doing that?
You want to do the nitro.
Huh?
You want to do the nitro. You want baby, that's what I'll take forever.
Well, the baby aspirin will help possibly help dissolve the clot, and the nitro will dilate the blood vessels around the heart. So the most important thing is delivering oxygen, okay? When we're breathing normally, we're breathing, I believe, 21% oxygen, and our lungs are inflating and deflating in a normal situation. If for some reason our lungs, if you think about the elasticity on a balloon, That's what's happening with your lungs. And if for some reason they're not inflating and deflating properly, you can increase the amount of oxygen that's going into the lungs by providing supplemental oxygen. So you can go from maybe 21%. So in other words, if you're not breathing efficiently, you can compensate for that by increasing the percentage of oxygen in the air that you're breathing. Okay? So that's why you add oxygen. If the patient doesn't have the ability to inflate their lungs on their own, then instead of passively increasing the percentage of oxygen by just simply adding some oxygen, you have to literally blow the balloon up, and that's what you do with the ambu bag. Okay? So if you look up on the top here, this is an ambu bag where if this mask has to create a complete seal around the nose and the mouth, and we're gonna demonstrate that in a few minutes. And this part of the bag is what you use to push the air into the lungs. Now it's not going to make it in there if there isn't a good seal and the patient's airway isn't open. When their head is down here, the airway can be cut off. So when you tilt their head back, you're opening up the airway. Then you're creating a seal. Then you're pushing with the bag, which is pushing the oxygen into their lungs. And this last bag here is where the supplemental oxygen is stored so that when you squeeze, it's filling up the bag with oxygen. So then you need to hook this bag up with this tubing into your oxygen source. There's a couple different systems for delivering positive pressure oxygen. The one that I just showed you with the ambu bag, you do with your hands. This system right here, where you see the mask and the bag below it, this is not positive pressure oxygen because it's a full face mask, and this is just a reservoir of oxygen. So this is for the patient that's breathing on their own but not breathing very well. So this will increase the percentage of oxygen from 21% up to 50 or 70% every time they breathe in, but they have to be breathing on their own. The ambu bag that I showed you in a few minutes is for the patient that's not breathing on their own, where you have to physically push the oxygen in there, okay, blow up the balloon. This particular mask right here, which a lot of offices have, is a demand valve mask, where if you put the full face mask on them and they're breathing on their own, it sort of acts like a scuba mask. They take a breath in, the valve opens, more oxygen comes in. On the other hand, if they're not breathing on their own, then you push this little button right here, and that forces the oxygen, so it blows up the balloon, okay? So that's why this is basically a 2-in-1 kind of situation where you can use it for the patient that's breathing a little bit on their own by just, they breathe in, it opens the valve, okay? And I want to take a few minutes and go back and get that oxygen set up that you guys have. And I don't know, let's see. So why don't we do that now? Because I think this is one of the most important things that we're going to do. If someone can go grab that oxygen setup you guys have that we just used a few minutes ago. Don't everybody jump up at once. Okay, I need another volunteer to lay down here.
4.
You guys wanna vote on this? Laura's stage fright. I usually go, whatever. Anyway, what is taking so long with the dying out here? Also, one of the things that I recommend is that every January 1st, you get in the habit of checking your emergency kits and make sure there's no drugs in there that will be expiring in the upcoming year. So one thing I don't recommend you do is say, oh, this is going to expire in March. We'll just wait till March to get that one fixed. Just every January 1st, look at any drug in your emergency kit that's going to expire within the upcoming year. Just replace all of them. The other thing that I recommend, and I think you guys are doing, is I tell people, put your emergency kit in the same place that you would put a fire extinguisher. That is, you see it every day. It's not in a closet. It's not, because that's what you want to have. That's the same place you want to have a fire extinguisher, where everybody sees it every day. Once in a blue moon, you'll maybe never need it, but you never know who's going to be here. So, and I think you guys do that. You have it back by the door here. Okay, now, if you're going to do an emergency drill, one of the straightforward things to do is everybody should everybody should be able to come over here and know how to turn this thing on. Okay, so what's involved? First thing you do is basically turn it on by turning this. Okay, and when you turn this, it opens up. So oxygen is now going through this regulator here. And this dial here is like a gas tank. That is, as the oxygen here depletes, it will slowly go down, just like with your gas tank. Okay, if there's half a tank, it'll tell you there's half a tank. Okay, so a full tank of oxygen is 2,000 pounds per square inch. So if you look at this one, it's a little under 2,000, okay? So this is like the gas tank over here. This is like the speedometer over here, meaning that when this is on 1, it's going 1 liter per minute, which is the speed of the oxygen that's coming out of this tubing, okay? So it can go 1, here's 0, half 1, 1.5, 2, 3, 4, 5, 6, whatever, liters, okay? And so you're going to want to probably go somewhere between 2 and 6 liters when you open it up. But again, this is how fast the oxygen is coming out of here. And then as this depletes, it'll go down from 2,000. Just as a kind of a side note, this is compressed gas, okay? So as it depletes, as I said, it goes down. Nitrous is different. A nitrous canister is a liquid, and the liquid evaporates, and the pressure on nitrous is 750 pounds per square inch. And when it starts dropping below 750, that means all the liquid is gone, and that means the tank is almost empty. So if you see a nitrous tank that's a little bit below 750, it's pretty much empty. That's the difference between oxygen and nitrous when you're reading the regulator, okay? So now that someone has turned this on, they've checked it to make sure that there's an adequate amount of oxygen in there. And I'm going to turn this off here. I'm going to take this thing out of there, and it's, if you'll notice in that one slide, we saw the mask had all the dust on it. That's why you want to keep it in this bag here. This is one of those masks that was in, like if a patient here, if this patient is breathing on their own, but they need, their breathing is shallow, then you can use this mask, okay?